We'll give it a few more minutes and see if anybody else joined us, and then we'll get started, okay? All right, good evening, everybody. This is Dr. LePage. Let me share my screen. All right. Y'all able to see the PowerPoint? All right. So
Yes,
let's
proceed.
Good. Good. Okay. So I'm Dr. LePage, and tonight we're going to talk about respiratory pharmacology and those medications we use to treat respiratory disorders. So we'll talk about our outcomes. Upon completion of this presentation, the participant will be able to apply the mechanism of action, proper use of inhalers, evaluation of care, patient education, and side effects of bronchodilators to specifically for the treatment of asthma and COPD. Apply the mechanism of action and proper use evaluation, patient education, and side effects of corticosteroids, and how we use them in the emergency treatment and the chronic care for patients with respiratory disorders. And then apply those pharmacological concepts of these medications to the care of patients with those respiratory disorders. So, what are respiratory disorders? Well, the first one we're going to talk about is asthma, and it is a chronic lung condition that affects more than 25 million people in the US, me being one of them. It tends to begin in childhood with most people. If they develop it as an adult, the symptoms do seem to worsen, and the patients have a harder time controlling it. It is characterized by that bronchial narrowing of those airways and swelling, excessive mucus production. Again, it is a chronic condition. And like I said, it does affect about 25 million people in the US. It can be life threatening and can be very scary for somebody who is not able to breathe or suffering from an asthma attack. And if you see in the schematic there, you can see the normal airways and then the airways to the right, or the bronchial airways of a patient who has asthma. Those airways are thickened and they are inflamed. They live in a constant state of inflammation. And then you add on that attack and that asthma and then the mucus production, and these patients can really have some difficulty breathing and suffer from that. So, what is an asthma attack? Well, when we breathe normally, our muscles around the airways are totally relaxed, and it lets the air move in and out easily and quietly. During an asthma attack, three things can happen. Patient can have a bronchospasm back in the airways. Those airways and those muscles tighten. And when they tighten, it makes the airways narrow. And you can see in the schematic to the right there, air cannot flow freely and it is very constricted. So these patients feel like they're not getting in enough air to breathe. Inflammation can occur, or all three of these can occur with an asthma attack. Inflammation is that those linings of those airways, and you can see again in the schematic there that they start to swell. The swollen airways don't let much air go in and out of the lungs, so ventilation and perfusion is limited on these patients. And then mucus production during an attack, the body creates more mucus, making that coughing, that bronchospasm brings on the cough. And these patients can, what typically they succumb to if they end up dying of an asthma attack, is the mucus plug that can't be mobilized or moved in those airways. When your airways get tighter, you make that sound that we call wheezing. Wheezing isn't necessarily all bad. There are days I wheeze all day long. At least I'm moving air. But when patients are not moving any air and you can't hear anything, that is worse. During an asthma attack, we really need to look at the patients and assess their work of breathing and not just look at the numbers or the pulse ox. Look at how difficult it is for them to breathe. So, types of asthma, it can be intermittent where it comes and goes. These patients can have no symptoms when they're not in an acute attack. and they can function normally most of the time. I have the intermittent type. Mine is caused by some food sometimes, some environmental stuff, and it's just allergies. Most often causes are mold, pollen, pet dander, and foods. I'm highly allergic to cats. I have one friend who has 8 cats, so I can't go anywhere near her house at all. When she comes with me somewhere, she has to change her clothes in the garage and then get in my car because it just sets me off into a really bad asthma attack. Some of the non allergic would be those environmental, tree, grass. Sometimes exercise can induce an intermittent asthma attack. Sometimes excessive heat and cold as well. There's also a thing called occupational asthma where these patients' COPD overlaps it. And also, those are patients like who develop asbestosis or due to the occupational and the chemicals that they've used in their job. Smoking can also bring on an asthma attack. I never smoked a day in my life and developed asthma at age 27. So there's also that persistent type, which their symptoms they have most days. It's all the time. It could be from mild to moderate to severe to acute, where they need to come in and be seen in the emergency room. The onset is usually adult, like I said, is more severe, and it would be an onset after the age of 18 years, and it's more prevalent in female. So mine started at 27. I'm female. Fortunately for me, mine is more intermittent and I don't have to deal with it every day. Childhood, like I said, they often do outgrow it, and it typically develops before age of 5, and then by time 5 or 6, they do tend to outgrow it. So why don't we talk about the different disease processes so that you can see how these medications can function and work with these medications? Anybody taking care of somebody who's had an acute asthma attack or know a family member? Nobody? Nobody's taking care of anybody that's had an asthma attack? You're pretty lucky. It can be scary for both the caregiver and the patient themselves. So, one of the biggest things is to try and keep the patient calm. Signs and symptoms were going to be coughing, shortness of breath. They could have wheezing. They could develop chest tightness, accessory muscle use, and then that increased work of breathing. And again, you can see the differences. See how those normal lung and airways are wide open versus the inflamed lung and airway in a patient. Remember, a patient with asthma. Remember, our lungs are smooth muscles. So we also administer any medications that are going to relax those smooth muscles. And we'll talk about which ones are those in just a few minutes. So, how do we diagnose asthma? Well, a lot of symptomatology, a lot of work of breathing. It's always difficult for these patients, and keeping a log of what might trigger it or might not. We can diagnose it by an x-ray. You can see some changes on an x-ray in the lungs. A CAT scan as well would be a little more specific. Doing spirometry and then pulmonary function tests are the indicative. The spirometry is going to measure how fast and how much of the air that the patient breathes in. And those pulmonary function tests are going to do that, just that. They're going to tell you how well the lungs function when the patient is taking a deep breath and then exhaling and trying to blow it out. So, how do we treat asthma? Avoidance therapy is going to be the first one, especially if it's an allergy. Bronchodilators, I have several different inhalers on the screen there. So the big thing that tends to confuse students a lot is an inhaler. It's an inhaled medication. We can inhale several different types of medications, but which one is the bronchodilator? That's going to be that two-tone blue one. That's albuterol, Ventolin, Pro Air. They're all the same medication. That's going to be your bronchodilator. That's what the patient is going to need during the acute attack. For maintenance, they can also take inhalers every day, and those are going to be your corticosteroids. Those corticosteroids are not going to work if they're in an acute asthma attack. So it's not really worth having the patient do it. It can sometimes irritate the patient and bring on more bronchospasms. They need those bronchodilators to open up those airways. How we give them corticosteroids would be IV in the form of solumedrol. And then remember, magnesium sulfate is a smooth muscle relaxant. So we may be administering magnesium sulfate in the middle of an asthma attack. Typically, it's 1 to 2 grams, and they get it over about 20 to 30 minutes to help relax those muscles and allow the ease of breathing to occur. Patients can be put on leukotriene inhibitors. Leukotrienes are our body's normal response to any foreign antigen that comes or enters the body, and those leukotrienes cause swelling. So think about a patient who has asthma. We don't want swelling in this patient, right? Because asthma or COPD itself increases swelling, and they already have swelling of those airways. So these leukotriene inhibitors, one is called Singulair and the other is called Accolate. Leuco Leuco forecast Leuco. I'll have to. It's on a slide. I can never say either one of them, but the Singulair is once a day dosing, and Accolate is twice a day dosing, and they're going to inhibit the swelling that occurs because of those leukotrienes when those antigens enter the body. The leukotrienes, those are maintenance medications. So again, in the middle of an asthma attack, we're not going to be giving them those leukotriene inhibitors. What we're going to give them is those corticosteroids to bring down the swelling, and we're going to give them IV so it brings it down quickly. Sometimes they've started using some biologics, particularly Dupixent, if it's allergic asthma or caused by allergies. And Dupixent has shown to be some positive effects. However, with the Dupixent, there are a lot of side effects, and it can oftentimes make the breathing worse. Any questions on asthma so far? Lost my cousin from this condition in May of this year. Oh, I'm so sorry to hear that. My patient had allergies to cats. Yep. I was never a real cat lover, so that's good for me, right? She suffers with persistent asthma. Wow. I'm sorry to hear that. You had an anaphylactic attack. That can be just as scary. Kind of the same thing happens as in asthma. The airway closes, you can't breathe. They probably gave you some epinephrine, the bronchodilators, and then the corticosteroids. Inhaled by a nebulizer or by through the oxygen on the wall is the best way to get that bronchodilator in these patients in an acute asthma attack. Sometimes they may need an hour-long treatment where it's more of the medication and they get it for longer. Can you explain more about diagnosis and symptomatology? Sure. What in particular are you looking for? So diagnosis and symptomatology, the symptoms that the patients have. We look at that can tell us a lot if it's an asthma attack because these patients are going to come in, they're going to either be very, very tight and not be having any airflow in their lungs. Their work of breathing is gonna be horrible. Their pulse ox may or may not be normal. I have the type of asthma where there's two different types, pink puffers and blue bloaters. My type of asthma, I can't get the CO2 out when I'm in the middle of an asthma attack. On a normal day, my pulse ox runs about 95 and I'm good. Right now, it's probably 95 if I was to check it. And that's good for me. If I'm having an asthma attack, I can't get that CO2 out. So my work of breathing is going to be very, very hard, and my CO2 level is going to go up. However, my oxygen level is going to be fine because I don't suffer from a lack of oxygen. I suffer from getting that CO2 out. So my pulse ox, if you do my pulse ox in the middle of an asthma attack, it may be 99 or 100, which is not normal for me. So that's why I use myself as an example to try and tell students, you really need to look at your patients and do really good assessments when we're talking about these things. Don't just look at the numbers. We have a saying in nursing, don't treat the machine, treat the patient. So don't look at the numbers. You really have to look at how bad the patient is breathing. So that's what we mean by symptomatology. Some of those other things, the chest x-rays can show, like I said, some changes, can also show if there's pneumonia on top of that asthma. And then the spirometry can measure how fast and how much air the patient is breathing in. Those pulmonary function tests we don't do in the emergency room. Those are done in a pulmonologist office. And we typically get a baseline and then they'll monitor them every 6 months to a year, depending how bad the patient or how many episodes the patients have in a year. Sometimes stress can bring on an asthma attack as well. Did that answer the question? Good. Okay, you get it. So let's talk about chronic obstructive pulmonary disease. It is a progressive airway limitation, causes tissue destruction in those bronchial airways and a lot of scarring. Those lungs and those airways lose that elasticity and the air sacs in the alveoli. So this affects even further down. Where asthma affects your airways and your bronchial airways, this is going to affect the alveoli all the way down in the bottom of the or not in the bottom, but in the innermost part of the lungs. Patients can have it in one or both lungs. Most often, especially if it's due to smoking, it'll be in both lungs. That air gets trapped again, and they can't get the air out, and it collapses those alveoli. So they're not the round like they should be. Progressively worsens over time. These patients definitely do need to stop smoking and talk about smoking cessation in order to once they have COPD or they're diagnosed, they can't, there is no cure for it, but they can stop the progression by stopping smoking. There are two types, the emphysema, which is typically due from smoking, and then the chronic bronchitis, somebody who has bronchitis and chronic airway issues and infections can also cause chronic obstructive pulmonary disease because that alveoli become very stiff and they're not able to breathe normally. Some of the causes and risk factors: alpha 1 antitrypsin deficiency is a genetic disorder that can lead to lung damage, especially COPD. Smoking causes secondhand smoke. So if you live in the house with somebody who smokes as well, a lot of air pollution, if you're in an area where there is a lot of pollutants, dust and fumes from chronic environmental exposure or repeated environmental exposure. Females over the age of 65 is when it typically gets diagnosed. And then also, thus, asbestosis as well can cause chronic obstructive pulmonary disease. And then frequent unresolved infections as a child. As that child gets older, that scarring in those alveoli and those lungs remains permanent. Complications of COPD: these patients can frequently develop pneumonia, hypoxemia, they can go into respiratory failure. It can lead to pulmonary hypertension or cor pulmonale. And if you're not familiar with what that is, it's just another name for right sided heart failure. They can develop a pneumothorax. And polycythemia is when the patient makes too many red blood cells. They're getting too much. Signs and symptoms of our COPD is a cough lasting more than 3 months, the inability to take a deep breath. These patients are short of breath with minimal exertion, and they may be on oxygen with a normal, for them, pulse ox of the high 80s with the oxygen on. So their pulse oximetry readings are going to be much less. They can have some wheezing, they can have some rhonchi, and then a barrel chest. I tried to find a adult picture with a barrel chest, but this is a child with some type of pulmonary disorder. You see how that he looks like a big barrel in his chest. And then they can develop cyanosis. With your COPDs, we also see clubbing of the fingers as well and the fingernail beds. We diagnose a lot of screening questions related to smoking. Do you smoke? Have you ever smoked? Have you had long term exposure to dust or air pollutants? Do other members of the family have COPD? Because it can be hereditary in some cases. Any other lung conditions or liver disease? Do you get short of breath with exertion or when resting? Most often, your COPD patients are short of breath even at rest, even with the oxygen on. Have you been coughing and wheezing for a long time? And do you cough up a lot of phlegm? And then again, your same test for asthma can be done to diagnose COPD as well. We do the pulmonary function test. We do ABGs on our COPD patients to get a good baseline of what their PaO2 is, that oxygen. Does anybody remember what the normal PaO2 is from a blood gas? That's something you might want to remember. It's 80 to 100. We can do chest x-ray, CT scan, and to see that scarring, and also an EKG, because sometimes these patients who have COPD, because they've lived with it for so long, they can have some EKG changes. And then we do an exercise walk test, which should last about 6 minutes. And they actually walk with a pulse oximetry on their finger, and a staff member or the person doing the test, typically a respiratory therapist, to see how far they can walk or how long they can walk before their oxygen saturation drops and before they start becoming very symptomatic. If they can't walk for more than 6 minutes without becoming exerted or short of breath, then it's considered they have failed their exercise walk test. They might need oxygen therapy, and then they'll retest them again after a certain time period to see how they do. They may get genetic testing done to see if there's anything in their genes that could have caused it as well. Treatment is going to be your smoking cessation for first off, bronchodilators, corticosteroid inhalers, and then these patients may be on PO corticosteroids for long term. Pulmonary rehab, where they actually go to the pulmonary center and they teach them how to do special breathing activities and how to monitor their breathing. And think about it, the lungs are muscles, right? We said they're smooth muscles. So if we can build up those muscles by exercising, that would be great, right? They might need a BiPAP machine or a CPAP machine, and then antibiotics for any co-infections. And we talked about oxygen that they may need continuously. So then we have to do a lot of education with that oxygen therapy. So let's work through a case study. You are the RN caring for a 70-year-old female who was recently diagnosed with COPD. The patient's history reveals hypertension and type 2 diabetes, which are both controlled with medications. Her social history reveals 1 pack per day smoker for 40 years. She says she has decreased to 5 cigarettes per day. She complains of shortness of breath with minimal exertion that has gotten worse over the past 2 days. Her physical exam reveals a barrel-shaped chest, use of accessory muscles with breathing, shallow breaths, a respiratory rate of 24, a pulse ox of 91 on room air, and bluish discoloration to her lip area. What's your evaluation of this patient's condition? Is she stable, unstable, or severely unstable? What would you all say?
Unstable. Severely
Unstable.
unstable.
Yeah,
Unstable.
I would say she's unstable. Absolutely. That bluish discoloration around the lips is not good. The respiratory rate of 24 in the presence of COPD is a little high. Her pulse ox is a little low, but it's not horrible. And she's using accessory muscles when she's breathing, right? So, what medication classification do you anticipate that the physician is going to order for this patient? What's going to be the first line of medication?
Bronchodilator.
Bronchodilator,
Albuterol.
absolutely. Those
What?
I'm sorry.
Corticosteroids?
It's going to be a bronchodilator first. The corticosteroids are going to be next, but you want to get those airway open so that they can get that inflammation decreased.
So that would
Um,
be the albuterol, right?
ma'am,
Would that be the albuterol?
yes. Your
Okay, thank you.
bronchodilators are going to be your albuterol, Ventolin, Pro Air. Pro Air comes in a inhaler only. You can't use Pro Air in a nebulized treatment. So this patient needs a nebulized aerosol treatment with the albuterol or Ventolin. It's the same medication. The action is they selectively activate the beta receptors in the bronchial smooth muscles that are going to lead to that bronchodilation versus that bronchospasm or bronchoconstriction. We use it for bronchospasms, acute asthma attack, and then an exacerbation of COPD. The routes we said were inhalation. The metered dose inhalers are the inhalers that you use, the rescue inhalers, and then they can get it PO. It does come in a liquid form, and we can give albuterol to kids in a liquid form. Side effects is it can cause tachycardia, shakiness, and tremors. And it's again contraindicated in pregnancy or anybody who has any tachyarrhythmias, hypertension, and heart disease. But again, we talk about the contraindications, but does that mean we don't give these patients these medications? No, they need it, right? They need to be able to breathe. So we're going to definitely monitor them closely and put them on a cardiac monitor if that's the case. We use the bronchodilators with caution with our MAOI inhibitors. Remember our antidepressants, both your tricyclic and your MAOIs, because it can increase the heart rate way too high, because that's what those medications do as well. So bronchodilators continued. The top one is our nebulizer, and then you see right below it the nebulized aerosol with the machine. I got the albuterol syrup there, and then the albuterol rescue inhaler. The last one, the yellow, this right here, is a spacer. We definitely should be educating the parents to use a spacer with children so that they get a more even dose and it doesn't go out into the air, because that's not going to do the patient any good, right? They need it in their lungs. Our nursing evaluation after we administer it is to monitor their heart rate and their respiratory rate. And then if they're taking inhaled corticosteroids at the same time, you want them to use the bronchodilator first and then rinse their mouth. You do not want them to take more than 2 or 4 puffs, whatever is prescribed for that patient, because then it's too much medication. So your patient received her albuterol via nebulizer, and evaluation reveals a heart rate of 122. Am I concerned about that heart rate?
Yes, Professor. It's
Why?
tachycardia
Well,
and
it's
would you
tachycardia.
pause?
It's tachycardia, but am I going to be really concerned? Because I just gave her a nebulizer
No,
with albuterol. So don't we
no.
expect albuterol to increase her heart rate? You're not incorrect. I would monitor this patient, but the point of it is to identify that albuterol is going to raise the heart rate. So this patient probably needs to be put on a cardiac monitor to make sure that she's not having any other symptoms or that the heart rate doesn't go too high. But albuterol is going to raise her heart rate. So knowing what the medications do can help us identify what our priority is and what we're really concerned about. Her respiratory rate is 22. Is that better than when we first saw her? She's come down. She was 24. And her pulse ox is 93 on room air. So is she getting better?
Yes.
Yes. The patient's lung sounds are diminished at the bases, and she continues to use accessory muscles to breathe. Her work of breathing is hard, and the patient states she's still short of breath. So, do we really think she's getting better? Her numbers look better, but what is her overall condition? We need to give her something else, right? What other kind of classification of medication does she need? And what do we give next?
Corticosteroid.
Corticosteroids,
Corticosteroid.
absolutely.
Corticosteroid.
Yep, that's steroid medication. And what is the medication that we give? What is the corticosteroid that we give?
Penicillin.
Anti-inflammatory.
What is it?
Penicillin.
Well,
Prednisolone, not prednisolone.
prednisone is PO. So it's methylprednisolone, which is your IV or Solumedrol. Because remember, we want to get it in quickly. Giving her that PO is not going to do much for this patient. We can give her some corticosteroid inhalers. Those you'll see there, your Pulmicort, your Symbicort, Flovent, Advair, and Breztri is a newer one, which are a lot of combination inhalers. Those might be maintenance inhalers. We use them for prophylaxis and maintenance control of that asthma and COPD. Some of the side effects are it's going to dry at the mouth and cause white patches in the mouth. And because they're on corticosteroids every day with this inhaler, it can cause immunocompromise and bone loss. and osteoporosis, especially in your postmenopausal women. Your corticosteroids, as we know, causes hyperglycemia, can lead to peptic ulcer disease, elevated white count as well, and then kind of masks the signs and symptoms of infection. And can also cause fluid and electrolyte imbalances, as well as increase their appetite. So they're great drugs, but they have lots and lots of side effects. So those are some of your examples of some of your corticosteroid inhalers. You see Advair over there is the purple one. Flovent is that orange one. The montecutazone is another inhaler, and then Pulmicort is on the far left of the screen. So, as far as nursing interventions, we want to monitor their blood glucose levels, educate them to rinse their mouth or brush their teeth after every inhalation, and provide really good mouth care for these patients. Because they are corticosteroids, we don't want them to stop them abruptly. We want them to taper the dose. Encourage weight bearing exercises to keep up their bone strength, and then increase calcium and vitamin D in their diet. We want to monitor for any muscle weakness and report any dark tarry stools and get occult blood if we see dark tarry stools. Also, educating these patients to avoid crowds because of the immunosuppression that they cause, good hand washing to prevent infection, and then monitor their serum and creatinine levels as well as their potassium. We also want to assess for edema or weight gain because these medications, corticosteroids, can cause swelling. Any questions? All right. So your patient has completed her nebulized bronchodilator and received IV Solumedrol, that corticosteroid. Her evaluation assessment reveals a heart rate of 102, respiratory rate of 20, no longer using accessory muscles when breathing, and she continues to have slight shortness of breath and no wheezing auscultated. She states she feels better and wants to go home. Is she stable? Do you think she's stable enough to go home?
Yes, she's stable.
Yep.
She's stable.
So the provider is aware the patient wishes to go home and prescribes albuterol via a nebulizer every 4 hours, Flovent 220 mics, 2 puffs twice a day. What type of medication did we say Flovent was? An inhaled corticosteroid.
You got an inhaled corticosteroid, right? Inhaler.
Yep, it's an inhaled corticosteroid. And a tapering dose of prednisone. So she'll start on 60 for 5 days, 40 for 4 days, 20 for 4 days, 10 for 3 days, and then 10 every other day times 3 doses. So, teaching of these medications. What discharge teaching will you provide this patient related to the medications? What are you going to emphasize with these medications?
We emphasize that you shouldn't stop corticosteroid abruptly.
Right. That's one.
Make sure they rinse their
Including
mouth every use. They use the.
Make sure they're increasing what?
Make sure
their mouth.
they rinse their mouth.
They rinse their mouth, yes. After the corticosteroid inhalers, absolutely. Yep. What else do we
And
want
that's
to
where
teach?
use spacer. You should use how to use spacer to Take the inhaler.
Yeah. What about prevent infection? Good hand washing. Because she's on corticosteroids, you see for how many days? That's 5, 9, 13, 16, 19. She's on it for about 20 days. So she can become very immunocompromised. So we need to educate them on good hand washing, all those things that we're going to try and help them to prevent from getting sick. Avoid crowds, maybe put a mask on if they're out in crowds. So there's a lot of education that needs to be done, right? Take your time. Don't try and do everything all at once. Allow for periods of rest as well. So
Um,
your
avoid
Yeah.
allergies that can trigger asthmatic attack.
Absolutely, yep. Avoid those things that can trigger it. Yep. So your leukotriene modifiers or your leukotriene inhibitors, we kind of talked about those a little. Remember, leukotrienes come and attack those antigens that enter the body. And these inhibitors are going to suppress the effects of those leukotrienes by reducing the inflammation, the bronchoconstriction, the airway edema, and the mucus production. We use them in COPD, asthma, and allergies. Accolate is twice a day, and the generic is a Furculast. And then your singular is your montelukast. And that one is dosed once a day. It's best to take it at night. And we use it a lot in children who have allergies. The singular is available in chewable form. Some of the contraindications of these medications, or they need to be monitoring closely, is the liver function test of these patients because they have been known to elevate and increase the liver enzymes. Side effects can cause depression, suicidal ideation, especially in your children, and abdominal pain, nausea, and anorexia. Some of our nursing interventions, we're definitely going to monitor those baseline liver enzymes, do good suicide risk assessments, and then monitor for signs of depression. And as I said earlier, it's best administered at night. There are some medication to medication interactions. The accolade is going to inhibit the metabolism of warfarin and theophylline, which can lead to toxicity in both of those. So, what would happen to a patient if they had too much warfarin? What's the complication of that?
Bleeding.
Bleeding.
Yeah, it increases their risk for bleeding. And theophylline is a medication that we used to use a lot for asthma attacks. And it's theophylline, aminophylline, and it is available PO and IV. And it's an IV infusion over typically about 45 minutes to an hour, depending on the dose. But theophylline levels it can increase the theophylline levels and lead to toxicity as well. And then the phenytoin can inhibit the effectiveness of the leukotriene inhibitors. Your methylxanthines are going to relax bronchial smooth muscles, leading to bronchodilation. And that is the classification of your theophylline. We use it in asthma, COPD, and then if some of the newer medications have failed. One of the biggest side effects or complications of theophylline is tachycardia. So we really need to monitor these patients. As I said, they can get it PO or IV. Side effects, you see the dysrhythmias and seizures. And then toxicity, the signs and symptoms are going to be severe nausea and vomiting or diarrhea. these patients become very restless. They become very tachycardic and hypotensive. The methylxanthines are going to interact with caffeine, and it's going to increase the incidence of those tachyarrhythmias, like I said. The phenobarbital and phenytoin is going to decrease. Also, rifampin is going to decrease the levels of theophylline. So it may take more and more theophylline to reach those therapeutic levels. Your cimetidine, ciprofloxacin, and fluoroquinolones can increase the theophylline levels to toxic levels. So it might be a good idea that you know the normal theophylline therapeutic index, and it is 20 to 80 micrograms per milliliter, and we measure that by serum lab tests. Our nursing interventions, we're going to place the patient on the cardiac monitor, monitor those theophylline levels, and educate about the side effects and about decreasing that caffeine ingestion. You do not want these patients to chew those sustained release pills because that means they get all of the dose at one time. Anything greater than 20 on the therapeutic levels could be considered toxic. So one of the other medications that we administer a lot to kids in the middle of an asthma attack is your inhaled anticholinergics, which is your ipratropium. It does block the muscarinic receptors of the bronchi to cause bronchodilations. We use it for bronchospasm, COPD, and asthma. This one does not cause the tachycardia and the tremors that the albuterol does. Some patients it works well, some patients need that albuterol. Ipratropium does not help me. You can mix it with the albuterol for me, and I still think it's the albuterol that works, but if you give me ipratropium by itself, it will not work. I need that albuterol. So the patients may need to be tried on it to see and see what the effects are, but it should not cause the tremors and the tachycardia like the albuterol. It is contraindicated in pregnancy and anybody who has a peanut allergy. There seems to be some cross contamination there. Side effects, it causes dry mouth, hoarseness. So our nursing interventions are going to focus around that. Good oral care, good mouth care. Allow the patients to have ice chips or hard candy to suck on if they can, if it's not contraindicated. And then monitor for symptom improvement, which would be the decreased coughing and the decreased bronchospasms. Does anybody have any questions so far? Yes, ma'am. May I know why is the side effect of theophylline is bronchodilation? Well, bronchodilation is going to open up those bronchial airways for the question with theophylline. Tachycardia is going to affect the heart. I'm not sure what you mean. Is it because of compensation? Can you elaborate or? Did that answer it, Nicole?
Yes, ma'am. Thank you.
Okay. So whatever your life's work is, do it well. So you guys are on your way to passing NCLEX. Do you want to do some practice questions? So the nurse is caring for a client with asthma who is experiencing wheezing and shortness of breath. Which of the following medications should the nurse administer first? So this is a priority question.
Albuterol.
Albuterol.
Yep, your albuterol, absolutely. And then your salbuterol is a long-acting beta-2 agonist, and we use that as a maintenance. That's one of your corticosteroids as well. The fluticasone is your Flovent, which is an inhaled corticosteroid, and that keeps the inflammation down. And then your montelukast is that leukotriene inhibitor, and that's in a pill form. A nurse is caring for a client with asthma on albuterol. The nurse understands that which of the following is a common side effect of this medication?
Tremor.
D.
Yep.
Tremor.
Tremors. Yep. And it's the tremors are caused because of that beta-2 adrenergic stimulation of those skeletal muscles. It's usually mild and it's transient, which means it'll go away once the medication leaves the system. Does not cause bradycardia. It'll cause tachycardia. Typically, constipation is not associated with the use of albuterol, and then dry skin is not a side effect. So that's one of, if you didn't know, you kind of narrow it down by looking at your answer choices. A nurse is teaching a client prescribed fluticasone for asthma. Which of the following instructions should the nurse include?
Rinse your mouth after each use.
Bravo.
Yep. Rinse your mouth after each use. We may tell them to reduce the salt intake because, again, remember, this is a corticosteroid that can cause weight gain. But the most important is that rinse the mouth after rinse the mouth after each use. You can use this for a quick relief. It is not a immediate relief. It's not considered a rescue inhaler. It's considered a maintenance inhaler. And then stop the medication when your symptoms subside. That's incorrect because these patients are on these medications long term to prevent those asthma attacks. A nurse is educating a client about using a metered dose albuterol inhaler. Which of the following instructions should be included? So this is one of your select all that apply questions. So there's going to be more than one correct answer choice.
B, C, D.
C, D, E.
Okay, so I heard B, C, D, and then C, D, E. So the correct answers are C and E. You want to shake the inhaler before use. And we do that to ensure that the medication gets mixed evenly within the canister, right? Or the aerolized canister. And exhaling fully before inhaling, which is answer choice E, allows for deeper and more effective medication to be brought into the lungs. It does maximize the medication's reaching into the lungs. We want it to go all the way down. The patient should the patient should inhale slowly and deeply, not quickly and shallowly, as in answer choice A. And then we do not want them to hold their breath for 20 seconds after inhaling. We want them to hold it for about 10 seconds. 20 seconds is a long time. especially somebody who is asthmatic, it's about 10 seconds because most often they have a hard time holding their breath for 20 seconds, which doesn't seem difficult for somebody who doesn't have asthma, but somebody who has asthma, 20 seconds could be a lifetime, especially if they're in the middle of an attack. A client presents with a severe asthma exacerbation. Which of the following?
I have a question for the other one though. Why isn't it that they don't rinse out their mouth immediately after use? Or is that only for corticosteroids?
That's for corticosteroids. This is your bronchodilator. Your bronchodilators you can tell them to rinse the mouth, but it's not necessary with your bronchodilators. Your corticosteroids tend to cause thrush. A client presents with a severe asthma exacerbation. Which of the following medications should the nurse anticipate to administer? Again, it says select all that apply.
All right. It's BCE.
DCE. IV, yeah, producer, yeah.
So I heard a whole bunch of answers. Let's talk about that for a second. So I didn't hear A, which A is an incorrect answer choice, but why is it an incorrect answer choice? Salbutamol we use for maintenance, not immediate relief. Answer choice B, your nebulized albuterol is correct. And answer choice C, your IV methylprednisolone is correct as well. We're not going to give them oral and IV in the middle of an asthma attack, which would be answer choice D. We're going to give them that IV because the IV works quicker. We're typically not going to give them the ipratropium bromide inhaler because they need a nebulized treatment. The inhalers typically aren't going to do anything immediately, especially if they're having a severe asthma exacerbation. We want to get that nebulized albuterol in them. So be careful with the words and the routes of administration when we're looking at some of these questions. The medication may be correct, but ensure that the route is correct as well. Does that make sense?
Yeah, thank you.
So that means E is incorrect?
The answer is B and C. Yes.
Okay.
D,
thank you.
in a severe asthma attack, you're going to give the IV form of that corticosteroid, not the oral. A nurse is educating a client about common side effects of salbutamol. Which of the following are common side effects?
C.
So if you're not really sure, remember it is considered a longer acting bronchodilator and a beta adrenergic, so it can cause tremors. Insomnia, nobody's ever died or had a bad attack or a bad outcome because of insomnia. They may not be able to function great, but it can be troublesome. C, your nausea. Again, it doesn't take precedence over D, which is a headache, because what could a headache be? A headache could be intracranial pressure, increased intracranial pressure. It could be a vascular headache because this medication helps dilate and it causes some vascular changes as well. Dizziness is not typically a side effect experienced with this medication. A nurse is educating a student nurse about montelukast. The nurse understands that its mechanism of action is what?
A. A.
A? Okay.
Yeah.
Are you reading the other answer choices? Or are you 100% sure it's A?
B.
Yes, I'm very sure.
Okay, if you're 100% sure, you are correct. But I really encourage you all to read all of the answer choices because just this is a test taking strategy. Because just like this one, a lot of people wanted to pick E because of the medication, but didn't completely read the route, right?
Yeah.
So just make sure you're reading them. A nurse is educating a client on a corticosteroid inhaler for asthma. Which of the following instructions are essential to include?
A.
What is it?
C.
A.
I hear A and D.
C.
C.
C. C.
C.
Y'all are all over the place on this one, right? So it's a corticosteroid inhaler for asthma. We are not going to use this inhaler for immediate relief
Oh.
during an asthma attack. We use a bronchodilator. Take the
C,
medication
yes,
with
C.
use to improve absorption. It's inhaled. It's not going to be absorbed. It's going to be inhaled. So that's two different routes of administration. So we're going to throw out A and B. C, monitor your blood sugar levels twice a day. It's a corticosteroid. They may need to monitor their blood glucose levels. And then stop using the inhaler when your symptoms improve. Remember, we said those maintenance inhalers, which are your corticosteroids, these patients could be on them for the rest of their life. So the correct answer is C. A nurse is caring for 4 clients. Which client should the nurse assess first?
D.
D is in
D.
dog?
D as in dog.
D as
Yep.
in dog.
D is in dog.
D as in dog.
D.
Yeah.
Yep. D is in dog. A client with asthma using accessory muscles to breathe, right? That
Yeah.
means that patient is in some type of distress. So, which out of those, put them in order, which one would you see next?
A.
A.
A is correct. And then after that, which one would you
B.
see?
B.
The
Bravo.
B.
B.
C.
No. B.
C.
The one experiencing
B.
tremor.
B.
B. Then C.
I
So
like this question.
it would, if it was me, I would, D is correct. I would see D first. I would see A next because this patient is still having dyspnea and they're ambulating. So they're still having distress. I would see the client with pneumonia awaiting a chest x-ray next because what if that pneumonia got worse? Tremors, we know, are completely normal with albuterol. As long
Yeah.
as she's not having chest pain or anything else, all it's saying is tremors. And that's the normal side effect of albuterol. So if I was to put them in order, it would be D, A, C, and then B. Does that make sense?
Yes. Yes, ma'am.
Yes.
A nurse is caring for a client with asthma who is on albuterol and reports having chest palpitations. What is the nurse's first action?
C. Assess
C.
the heart rate.
B. Notify.
C.
So C is correct. I heard document the symptoms in the chart. So remember, this is a priority question because it wants to know the nurse's first action. So ask yourself, what is documenting the symptoms in the chart going to do to save or help my patient right now? I call that a do nothing answer choice. Remember, with your priority questions, you're going to do all of them and you are going to document the symptoms in the chart, but that's not the first thing you're going to do. Remember, you always go to your patient first. So we need to assess the client's heart rate and rhythm. We need to do a more focused assessment on what she's complaining on, right? And then I heard somebody say inform the healthcare provider. Well, you're going to inform the healthcare provider after you see the patient, right? After you go and assess the patient, because they're going to want to know what's the heart rate, what's the rhythm, what's going on with the patient.
For your best friend's fun.
I'm sorry. So if I was going to put these in priority order, it would be C, and then B, and then reassure the client that it is expected, and then document the symptoms in the chart.
Yeah.
Does that make sense?
Yeah.
So that didn't take as long as I anticipated it taking. Does anybody have any questions? Do you need any tips? Professor, nebulized albuterol is not inhaled route like ipratropium inhaler. Right. Albuterol nebulizer is by a nebulizer. So they're holding the peace pipe and it's hooked to oxygen. It's a nebulized treatment. Your albuterol inhaler is just that. It's an inhaler. So the ipratropium is incorrect because that's an inhaler. With that question, that patient was having a severe asthma attack. And that severe asthma attack, they need to get those airways opened. And we're going to do that with the best route, which is that nebulized inhaler. Anybody else have any questions? No questions? Come on, you guys got 45 minutes here. What can I help with?
Professor, please, I want to ask, is it possible that they will ask us to calculate how to get peak flow meter?
No, I don't think they
In
would.
NCLEX?
I don't think they would ask you. And if they do ask you to calculate a peak flow, remember, you know what the peak flow meters are? You put the arrow down at the bottom and they do their peak flow, you get the number, and then you put it back to the bottom, and then it's the average of the three. Side effects of
Thank you, ma'am.
Side effects of salbutamol are where's my one on salbutamol? Salbutamol is your it's going to be the tachycardia, the same as your bronchodilators, because oh, now my thing is scrolling. Sorry if I'm making you dizzy. I had a question on salbutamol here. That's what I'm looking for. So your salbutamol inhaler is going to have the same side effects as some of your bronchodilators. It can still cause tremors, can still cause increased tachycardia as well. Any other questions? The difference between your salbutamol and your albuterol is salbutamol is more long acting, more for maintenance, and your albuterol is your rescue inhaler. Please show all screens before the topic. Let's talk bronchodilators. That's all of those are just on asthma and the disorders. Which one are you looking for in particular? Which one were you looking for? Okay, the first 10. Yes, the slides are posted. Yes, I can go back and talk a little bit about them since you joined late. Slide 35. Let me find that one. It's A and D, the tremors and the headache. Okay. So basically, we just talked about what asthma and the difference between asthma and COPD, gave you a little bit of a background so that you can identify why these and how these medications work. Asthma causes the narrowing of those bronchial airways and swelling of those airways. And as you can see in the picture there, it's in the actual bronchial airways. So it does not affect the alveoli, whereas COPD is going to affect the alveoli. It is a chronic condition and it affects about 25 million people in the US. Sometimes it can be life-threatening, and the reason it becomes life-threatening is because that mucus plugs in those airways, and these patients go into respiratory distress and respiratory arrest. If I was studying and wasn't really sure on them, I would do a side-by-side column of what COPD is and what asthma is, because there's a lot of similarities, but there are differences as well. In where it affects in the bronchial airways is one of the big difference. The COPD is in the alveoli, way down in those, the grape-like clusters, whereas asthma is in those bronchial airways, which are even bigger. And the causes are different as well. Asthma attacks, 3 things can occur. All 3 can occur, or just one can cause an asthma attack. They can have bronchospasms, where those muscles constrict and tighten, and it's just that they spasm. When they tighten, it makes those airways very narrow and difficult to breathe. They can become inflamed with inflammation, and that's why we need the corticosteroids to bring down that inflammation. We use the bronchodilators to stop those bronchospasms, and then mucus production can occur. Not every patient who has asthma has mucus production. So just keep that in mind as well. There are two different types of asthma, the intermittent and the persistent. The intermittent is going to come and go and is usually triggered by either allergies or environmental stuff. Can be exercise, can be excessive heat or extreme cold. It could be occupational substances of people who asbestosis is one that can cause those chronic and asthma attacks. When the patients have intermittent asthma, if they're not having an acute attack, they're typically asymptomatic. And then they can typically function normally, except when they're having an asthma attack. The persistent kind is where most days they're having symptoms. They are having some type of symptom. It can be, and it's then further classified as mild, moderate, or acute. I'm sorry, mild, moderate, or severe. And then they can have those acute attacks as well. The onset for adults is typically after the age of 18, and it affects females more so than males. And then childhood, if they develop it during childhood, they'll typically outgrow it by the age of 5. Those patients who develop it as an adult have more severe symptoms related to it. Your signs and symptoms are going to be again related to the narrowing and the inflammation of those airways. These patients tend to cough, short of breath, they may have wheezing, and they may have very little air moving in and out. Sometimes they have some chest tightness, use of accessory muscles, and then definitely an increased work of breathing because they're trying to breathe. We diagnose it with their symptoms and we monitor their work of breathing. We do the pulse oximetry, but again, I caution students and nurses to not rely on that pulse oximetry reading, but look at your patient. How bad, how hard is it for them to breathe? We can do chest x-rays to make sure they don't have pneumonia. And then the spirometry measures how fast and how much air they can breathe in. But again, in an emergency situation, we're not doing those spirometry or those pulmonary function tests. We're treating their symptoms and how hard it is for them to breathe and what their lungs sound like too. Treatment, we want to do avoidance therapy if it's allergic. Bronchodilators are our first line, which is your albuterol. And then maintenance corticosteroids are done daily. And again, if they're in the middle of an asthma attack, they're not doing those maintenance corticosteroid inhalers. We also give corticosteroids IV in the middle of an attack. Then they'll probably, or they do go home on a PO taper dose of the corticosteroids, the prednisone. Mag sulfate is a smooth muscle relaxer, so patients will get an infusion, typically over 20 to 30 minutes of 1 to 2 grams of that magnesium sulfate. And then your leukotriene inhibitors are for long-term maintenance of these inflammation, for that chronic inflammation. And then biologics, which the most common one would be your Dupixent. They have a lot of side effects, and they're not well tolerated in some patients. Are we good with that?
Prof, I would like to ask, is the treatment for asthma attack the same with status asthmaticus, or is
Yeah.
it different?
Yes. So, well, an asthma attack, status asthmaticus just means that bronchospasm and that swelling is not resolving. It's just an attack that's having a long period of time.
Thank you, Prof.
So, between COPD exacerbation and asthma attack, which is the priority when both are airway and breathing compromise? So, they're not so much airway up here, it's the bronchial airways. There's no clear answer for that. It's not one or the other. You would need to take a look at the patient. I may come in with an asthma attack, but it may be a milder asthma attack versus you'd have to look at the symptoms of those patients and see which one is worse. And we go by, remember, looking at the patient and looking at the work of breathing, not necessarily the pulse ox, because a patient who has COPD could be on oxygen and have a pulse ox of 88, but they're fine, or that's their normal, that's where they live, versus somebody who's having it. If I had an 88 pulse ox, I would be in some severe distress. So you really, that's not a clear cut, well, you're going to do this one or you're going to do that one. You would have to look at the circumstances or the scenario that you're given if both those patients are there. Does that make sense?
Yes, it does, Prof.
Where can I get these notes? What notes? The slides? My notes are in my head, so I can't get you that. Sorry. The slides are on previous recording or previous sessions. And you should be able to see the slides as I'm talking. I'm trying to see if I got all the questions answered. Okay. So let's talk about COPD a little. It is progressive airway limitation. And again, it's in those alveoli sacs. So remember from anatomy and physiology, the difference between the bronchial airways. We're not talking airway up here. We're talking bronchial breathing airways. There's a lot of scarring in these patients with COPD. And most often it's caused by chronic exposure to harmful substances, most often that nicotine. It can affect both or one lungs. These patients tend to have what we call black lungs, where that scarring and that blackness from all the smoking or that secondhand smoke. They tend to get air trapping, and that's in that alveoli, in that cellular level. It progressively worsens over time, and there are two types. That emphysema is from smoking, and the chronic bronchitis is they typically get bronchitis very frequently, and it could lead to that scarring. These patients with COPD lose the elasticity of the airways and those air sacs, so they kind of become shriveled, more like raisins than a bunch of grapes. Causes and risk factors: your alpha 1 antitrypsin deficiency is a genetic disorder that we see with genetic testing. These patients who have COPD, smoking, secondhand smoke, and then highly pollutant areas and cities, dust and fumes from some of your environmental exposures or work related, depending on the chemicals. Asbestosis is one of them that causes chronic obstructive pulmonary disease. We tend to see it in more females over the age of 65. And then those patients who have had frequent unresolved respiratory infections as a child can develop that scarring in the lungs. Some of the complications is these patients, because those alveoli are flattened or shriveled, they can tend to get pneumonia, hypoxemia. They can develop respiratory failure, pulmonary hypertension, and then cor pulmonale is just right-sided heart failure. They can develop pneumothoraxes, and then polycythemia, which is your condition where the patient makes too many red blood cells. Lots of times your COPD patients are intubated um, more frequently than your asthmatic patients. Signs and symptoms of COPD is a cough that lasts more than 3 months. These patients have a hard time taking a deep breath, and they get short of breath even with the most minimal exertion. They tend to have wheezing and a rhonchi cough, and then a barrel chest. And I was saying I couldn't find a picture of an adult with a barrel chest, but that little kid surely has a barrel chest. And then these patients develop cyanosis. Typically, it's called circumoral cyanosis, typically around the mouth and in the fingers. They also develop clubbing in their fingers. We diagnose it with a lot of screening questions related to smoking. Those are some questions that you might want to ask. Sometimes these patients don't smoke, or they smoked very infrequently many years ago, but they still can develop that COPD, and it has permanently scarred their lungs. We diagnose it with pulmonary function tests and ABGs. I did talk about the normal arterial blood gas. The PaO2 is 80 to 100. Chest x-ray and CAT scan, we can look for those changes in the lung tissue. And then the EKG, because it can cause some cardiac changes as well. We do an exercise walk test where we put a pulse ox on these patients, and we walk them for 6 minutes, or try to get them to do a 6-minute walk test, and see how frequently or how often or how low. We're just assessing the pulse oximetry on them, and then if they need oxygen. And then sometimes they'll send them for genetic testing. The treatment is going to be your smoking cessation, just like your asthma, your bronchodilators, your corticosteroids, IV if it's emergent, corticosteroid inhalers long term. And then these patients can go to pulmonary rehab, where they actually teach them, and they participate in an exercise plan to build up their lungs. Because remember, the lungs are smooth muscles, right? So we can build those muscles back up. They might need a BiPAP or a CPAP machine. And then if they have any co-infections, they may need some antibiotics for that frequent pneumonia. Sometimes and often these patients are on oxygen therapy for the rest of their life. So was that helpful? That's where we started, and then we started talking about the case study and the medications. So does this mean COPD can progress to lung collapse or atelectasis? Absolutely. Because pneumonia is like your atelectasis, and a pneumothorax is where the lungs can collapse as well. Yes. I think I need now a studying partner. Where can the live tutoring be found? This is live tutoring right here. I think I need a studying partner. Okay, that's great. You guys definitely get study partners. That's definitely helpful, and bounce it off of each other, right? You're not seeing my slides because I took it off just now so I could read the chat. Any other questions? When are you all taking boards? Taking NCLEX? July? Okay, early August. So study plans and techniques. Really read those questions. Look for those keywords next week. Good for you. Look for those keywords. Kind of like the one that we talked about that had where is it? Sometimes reading the questions too quickly, like this one here. Make sure you're looking at the route of administration and not just the medication as well. Because ipratropium, if it was nebulized, or might be a correct answer because it's a select all that apply. But because it's inhaled, that's not going to work as quickly. And these patients who are having a severe asthma exacerbation need medications quickly. So if you're going to pick the IV methylprednisolone, we're not going to pick the oral prednisone as well, because that patient will go home on that oral prednisone. But right now, what are we going to do right now for this patient in that severe asthma attack or severe asthma exacerbation? Does that make sense? Are you guys practicing questions? For those of you that are taking it soon, that is what's really going to help you, is practicing those questions. Yes, every day. Good. Good. Yes, yes, good. Any other questions that you guys might have? These two are kind of simple. Is it best to study by systems? So I tell students no, because your patients don't come in with just one problem, right? They come in with a whole host of problems. So if we call it siloing or compartmentalizing. If you're compartmentalizing by system and not tying it all together, that's where students are losing, because these patients don't come in with just one problem. They come in really doing case studies would be very helpful. It would be very helpful if you get and do case studies and do a lot of the questions, a lot of the NASLEC questions, especially the readiness assessment tests. They have case scenarios where you're actually answering questions related to the nursing process and caring for that patient at the same time. So you're going through, you're doing an assessment, you're recognizing cues of whatever disease process, you're analyzing those cues, you're coming up with a plan, then you're doing an intervention, whether it be a medication or a skill set, and then you're doing an evaluation. So if you're not familiar with the systems and you struggle with one or a particular system, I would go back and study that body system, but I would not study them separately, because our patients are a whole. They come in as a whole person. I will be starting to tutor for NASLEX one-on-one tutoring. Any other questions?
Prof, can you please elaborate about the bronchitis and what's this one? Emphysema, because they have different clinical manifestations, right? They can be I always confuse them which one is the pink puffer and the blue bloaters.
So those are typically more with asthma. Your pink puffers are your ones that their oxygen levels are good. That's why they're pink. They have good oxygen, but they can't get CO2 out. This is how I think about it, and this is how I remember it. Your pink puffers, they're pink, their color's good because their oxygen level is good. The blue bloaters are those where their oxygen levels are very poor. So a lot of times your COPD patients they need oxygen, right? They're on oxygen, so they're going to be your blue bloaters. I've never heard of that in relation to bronchitis because chronic bronchitis is more like an infection, and having chronic bronchitis over and over can lead to COPD. Does that help?
Yes, it does. Thank you.
Do you know when you will start? When will you be starting? I am not sure. I'm waiting for them to let me know. I'm doing people were asking for EKG content. So starting on, I believe it's the 25th, I'll be doing EKG. So right now I'm working on that class as well for NASLEX. So I believe it starts on the 25th. Yes. The EKG is the 25th. I'm not sure what the charge is for that. That would be a NASLEX question. I don't get involved in the charges. Do you know when? Yeah, I don't know when yet about the tutoring, one-on-one tutoring. I am, like I said, I am doing the EKG because a lot of people were asking about EKGs. So I offered to do, I think it's going to be 4 sessions. I will let me find my calendar and I'll tell you what time. It should be posted on the NASLEX site, but give me a second and I'll. It's 7 to 9 on the 25th is the first EKG. And then actually they're all 7 to 9 on the following 4 Wednesdays. So July 2nd, July 9th, and July 16th. So what time? Okay, Floxy to everyone. What about ARDS? So ARDS is adult respiratory distress syndrome. That is an acute, it's not really like asthma or COPD. It's not under the same classification. ARDS occurs after an infection, after the patients are intubated for a while, after they've had surgical procedures where they go into that respiratory distress. Lots of times it can be fatal for these patients because it's a result of now their lungs and their bodies, their major organs of their lungs have now collapsed and they go into distress. It's typically due to whatever complication underneath. That's a good point. I need to tell them. And we use the same medications for ARDS. I'm going to make myself a note to maybe add ARDS to it as well. But you use the same medications. You're using your bronchodilators, you're using your corticosteroids. You're probably going to add antibiotics to an ARDS patient as well, if not more than one, because it's typically related to that infection. A lot of nursing care related to preventing ventilator associated pneumonia as well, and lots of bronchodilators and corticosteroids. How should I be studying having my exam in the middle of August? Should I be doing questions only to build my content knowledge? I tell students you should be practicing at least 50 questions a day. Make sure when you're practicing questions, don't just get the correct answer and that's, move on if you got it correct. Really read the rationales. Why is it correct? And why are those other answers incorrect? You can do a lot of learning that way. When I had to take my emergency nursing certification exam, I learned a lot about content that I didn't know from reading the rationales. So therefore, it was able to help me answer future questions or questions further on down related to the same topics. If I didn't know a answer choice or what something was in one of the answer choices, I went and looked it up. We at the college I work at full time, we use Lippincott products, and we started talking about the laundry list. So a laundry list is, and I make laundry lists. I don't know if you can see that. That's my notes. I don't particularly use sticky notes right now. When I'm at home in my personal desk, I do, and you'll see sticky notes all over my desk of things I want to look up or things I need to look at further or things I need to do more so for students. But I do use, so make a laundry list of those things that you're not familiar with and then go back and look at those. I would not be at this point, if you're getting ready to take it, I would only be studying the content that you're not familiar with or that you struggle with. So, if you're, pick a topic. If endocrine is a difficult topic for you, I can talk to you about diabetes all day long, but some of those other endocrine disorders, I really have to go back and look at. So for me, on my laundry list, I would put diabetes insipidus. I would put some of our endocrine disorders, Cushing syndrome, and some of those I would put on my laundry list. Does that help? So neither COPD nor asthma can lead to ARDS. I don't know that that's a all or nothing answer. I do not believe so because ARDS typically occurs after an infection, after a surgery. I would have to look that one up. I'm making notes right here. I'm making my laundry list for what I'm going to add to it. Mental health and maternity are my weak areas. Well, I'm right there with you with maternity. Mental health, it depends on what it is. There are sessions on mental health as well. I know I do mental health medications and talk about some of the mental health disorders. Maternity is not my specialty at all. I can talk to you about maternity medications, but not maternity. Oncology is my weak area. So don't be so stressed about oncology being your weak area. What I tell students as far as oncology is because NCLEX is probably not going to test you on specific medications related to oncology because there's so many, and there's chemotherapy, and administering chemotherapy is very specialized and requires a lot of specialized training. What NCLEX may ask you related to oncology is how are you going to take care of that patient? What are you going to prevent from happening in a patient who has a cancer. It's going to be infection. So you're going to do whatever you need to do to prevent that patient from getting sick, whether it be, and then ask yourself, what does that look like? What am I going to physically do? Well, you're going to put them on probably neutropenic precautions. You're going to avoid crowds and not let a lot of people in the room. You're going to make sure that you as the nurse and the other caretakers are doing good hand washing. We may have to wear a mask as a caregiver. What are some of the complications of chemotherapy as a whole? Well, these patients have decreased white blood cell count, so they can't fight off infection. They could have decreased platelet counts, so that could cause bleeding. So think about the overall with that, and don't get into the real specifics. You do need to recognize some of your major cancers when it comes to like health promotion, and that would be your screenings, right? Health promotion screenings for breast cancer, for colon cancer, lung cancer, leukemias. How do we know? What do we need to screen for prostate cancer for males? Trying to pull the stuff off the top of my head and it's late. Was that helpful to answer that oncology question? As far as mental health, it depends on what you're referring to as far as mental health. It is a lot. Yes, it is a lot. But once you pass NCLEX, you have a lifetime to learn the rest of it. I've been a nurse 36 years and I'm still learning. And I'm still looking up stuff and I'm still having to go back and do things. If you all are doing study groups with each other, I tell students and I suggest to pick a topic and one person learn that topic and teach it to the rest of the group, because that old saying, see one, do one, teach one, really helps. I mean, I can see it. Maternity, I could probably teach it if I had to. I've seen it. I've been pregnant. I've had kids. I've taken care of pregnant women and laboring women in the ER. Do one. I've helped deliver babies and take care of these women, and then teach one. I have to learn it for myself. So kind of anticipate what questions somebody might ask so that you're delving in a little deeper. Good questions, you guys. My exam is in August. What should I focus on the NASLEX I subscribed for? So definitely your readiness assessment tests and the tutoring sessions just to gather more information. But practicing a lot of questions is helpful. And like I said, those readiness assessment tests are really good because there are a lot of case scenarios in there. I also do recordings for NASLEX on those readiness assessment tests. I'm a little behind on them, but I am working on them. And I kind of talk through, and so do all the tutors. Everybody works on those. So once you subscribe, you can go back and listen to those and practice those questions. And then really identify where your weak areas are. Because what you're going through. You can see if one particular content area is your weakest, then I would focus on that. Any other questions? Thank you. I like doing them. I like helping students as best I can. Do we have session today at 9? I am not sure. You would have to look at the NCLEX schedule. Somebody said yes, we do. I'm not real sure what this session was. This was an added session for me. Which one you would recommend reading assessments or CT exams? They're all good. The questions are all good on both of them. The readiness assessment tests are gonna they have more questions and they're 110. So that would be more in line with NCLEX because you can get anywhere from 85 to 160 questions. Where can I find this lecture? It'll be on the site. Somebody put in here the next lecture is on, the one tonight is on adult ear disorders. Where can I find this lecture? It'll be in previous recordings. All right. Well, if nobody has any other questions.
I was going to ask a question.
Sure.
Hello, Professor.
Hi.
So I wanted to ask, I hear people say when you take readiness assessment and you keep making high chances and you've taken 4 times and it's still consistent with high chances, that it's best to go take the NCLEX. I wanted to know how true that is.
So if you're getting high scores on the readiness assessment test, that's what it's for. It's going to help you, show you where you are ready. So if you're getting high scores, I would say then yes, that would be a good assumption. If there's areas that you're weak in, I would look at those as well. The day before the exam, I wouldn't study at all. I wouldn't take any tests. I would make that day for you. I know students, it's kind of crazy, but students are last minute. If you don't know it by the day before, you're not going to know it. And you're just going to become confused. I've had 3 students out of all the students that I've taught for the past 10 years. And we graduate students twice a year. I've only had 3 that told me, oh my gosh, I did not study the day before. And I was so relaxed and I was less stressed. So that's my suggestion. If you're scoring high, then I would try the test. Can I access replay videos, NCLEX schedule? I don't subscribe yet on 14-day trial. I'm going to let the NCLEX people respond to that. You can go to the website and see. I recommend that if you're not using anything, this is one of the best ones. I wouldn't work for a company that I don't believe is a good company in helping students. So they said, yes, you can on the 14-day trial. Where can I see the schedule? The schedule is going to be on the NCLEX website. All right. Well, if nobody has any other questions, I'll let you guys log on to your next one. And I hope you guys have a good night and weekend.
You as well. Thank you. Bye-bye.
You're welcome.
Thank you, Prof.
You're welcome.
Thank you, Professor.
You are welcome.
Thank you, Professor. Have a good night.
You too.
Thank you.
You're welcome.
Have a good night.
You
Be
too.
well. Take care.